All right, well, we'll go ahead and get started. Hi, everybody. Again, I'm Jay Ostrowski. I'm one of the Matrix board members, and I do a lot of digital health innovation stuff, like working with how to integrate with primary care as both a telehealth consultant and doing training and technical development. So I'm very pleased to have talked to these two great doctors that have been doing this work in different ways for quite a while. So I want to introduce for us first is Dr. Boylston with Burlington Pediatrics, and she's going to share her own slide deck. And then again, Dr. Christy Vo, MD, who's the head of psychiatry at VitaHealth. And they have very different company perspectives, but I think we're going to start with Dr. Vo first. Is that right?
Hi, thank you everyone for attending. So I will go ahead and share my slides. Hopefully everyone can see it. Give me a thumbs up.
That's great.
Okay, so thank you for attending today. As the name imply, we're talking about behavioral health integration models, and I'm actually going to talk about 3 models, 2 at CHOP and 1 at VitaHealth. And so a little bit about me, as Jay mentioned, I have recently left CHOP, the Children's Hospital Philadelphia, and now works for as VP head of psychiatry at VitaHealth. I'm also still remaining a part of the digital health team at CHOP and do what I can to help them out. So some of my conflict of interest is that. And part of this talk today is I'm going to talk about the software development that I did with Twilio as their grant recipient. So what are things I'm going to discuss today? Today, hopefully, in the next 30 minutes, I'll describe to you how to apply telehealth clinical models to fulfill behavioral health need using an example of CHOP, how CHOP uses telepsychiatry in primary care. I also talk about how can you identify a software solution to help fill the gap in your current primary care needs, but particularly for suicide risk assessment. So I'll give an example of how we did that at CHOP. And then also how to appraise triaging of clinical decision point using digital health, and how can that improve outcome? And I'll give an example of how Vita does that. So a little bit about CHOP. It's the nation's first children's hospital, and we do a lot of family center, high quality care, as well as innovation and research and medical discoveries. VitaHealth is a virtual care platform. It's designed intentionally to treat both mental and physical condition, and we use AI-powered personalized medicine to support patient through behavioral change with coaches and therapists to manage their chronic diseases like hypertension and diabetes. So as you may know, mental health landscape is that we are in severe shortage of psychiatrists and other behavioral health providers, and 55% of counties in the United States do not have any psychiatrists. So that leads to 4% of Americans who experience some form of mental illness goes untreated. And the average wait time for initial appointment is about 7.5 weeks. It's even longer for child psychiatry, and it's even longer for niche specialty like autism and developmental disabilities. So in terms of model of telehealth for behavioral health and primary care, the main concept that I want people to understand is that you can apply any type of model of telehealth to behavioral telehealth. You can on-demand, schedule services, business service, direct to consumer, store and forward, more commonly known as e-consult now. Any of that you think of for telehealth, you can definitely apply to telebehavioral health. So when you're thinking of how do you apply clinical models, think about what you need for your services, and whether on-demand it can fulfill it more, or whether schedule can fulfill it, or whether your organization is comfortable with marketing directly to the patient. And if you're partnering with another entity, then maybe e-consult would be a good form as well. So when it comes to the academic center at CHOP, we are closely affiliated with UPenn. I'm also a faculty at UPenn. And when it comes to a center like us, a lot of our needs are trying to fulfill our own internal mental health needs. There's long wait lists at CHOP. And then to fulfill our own internal need, what do we want to do? Well, we kind of think about how do we leverage our own resources to meet our own needs. But then, sometimes partnering with external community would also benefit us by meeting each other's need, as well as increasing our footprint, branding, marketing, etc. So for us, we started with meeting our own needs, and we have a huge intensive primary care network, 32 primary care sites throughout Pennsylvania and New Jersey. And we also have a psychiatry service in the emergency that is often overwhelmed, particularly during the pandemic. And we also want to think of post-hospitalization discharge behavioral intervention. And those are the main things that we thought there was a great need in. And so we start brainstorming about how can we fulfill those needs. So I came into CHOP back in 2018. And I was a big fan of the collaborative care model. And luckily, CHOP already had a form of collaborative care model going on in the primary care sites. About 16 of the sites already had a behavioral health expert at the site. And so I wanted to leverage what our current model has. It doesn't help to create something totally new. Definitely think about what you currently have that you just want to amplify with telehealth or telepsychiatry. So I felt doing telepsychiatry in the collaborative care model would be the best way to go and best way to start. Granted, this is before pandemic, so it was a heavy push to do telepsychiatry. We were just a new small team, me and another clinical director. So we decided to start with collaborative care. And for those who don't know what collaborative care is, basically the short is that typically the patient sees the primary care doctor. Maybe they might have access to psychiatry through a consult with the PCP, or they go see the psychiatry directly. But the PCP and the psychiatry are often not working together, and they're not working all closely together. In the collaborative care model, the ideal is that there is some sort of care manager, whether that is behavioral health expert or a NP or some sort of mid-level professional that is the main engager provider for the patient and interacts with the patient more regularly. The PCP also interact with the patient directly, but the psychiatrists only interact with the patient when needed. And they really work through the care manager to fulfill the mental health needs of the patient. And they talk to the PCP to tell the PCP and consult with the PCP on what the PCP could do in primary care. So it's based on the University of Washington Ames model. And one of the things that our personal aim for our own service is that we wanted to increase access to behavioral health and also upskill the pediatrician and the mid-level behavioral health clinician. So a lot of pediatricians are already, doing prescribing and psychiatric behavioral health management in primary care. So we wanted to make them feel more confident in doing so and train them in a sense by working with them. And as you know, access is an issue even in urban areas such as Philly. And there is a decreased stigma in going to the pediatrician office, and there's also a decreased cost and the distance and logistical barriers for the patient, as well as for myself. I don't have to drive an hour to one of the primary care sites, which we eventually did choose that site to do telepsychiatry to. So that is a great way to think about how can we incorporate telepsychiatry in what we currently have. Another reason why we felt this would work is that we want to leverage our own resources. We already had primary care provider. We already had LCSWs. We already had PhDs, behavioral health services. And if you don't have that, then you want to come up with more creative way of using what you could have. As mentioned in the collaborative care model, The care manager can really be a lot of things. Brainstorming, being creative is encouraged, but also to remind everyone, when it comes to the collaborative care model, the primary care provider is really the first line treatment, and ideally in primary care. And then it goes up from there. Then you get the ad hoc consultation with the off-site mental health specialist. Then you get the PCP supported by on-site behavioral health consultation, which is what we have at CHOP when the time I started this program. And the fourth is, the PCP really integrate into the care team with psychiatrists and the mid-level care manager. And then if needed, then you refer to a specialized mental health clinic, which CHOP, we do have our own outpatient mental health clinic, and we consider that as the last option. If needed, we would refer our patient to our own mental health clinic. So a few ways to think about how to actually functionally operationalize this work is you want to think about, do we want to provide only provider to provide consultation, or do you want to do direct to patient care? And so in the direct to patient care, it's really the telepsychiatrist to the patient. And then in the provider consult, it's really the psychiatrist and the PCP primarily. And the PCP is who works with the patient and the family. In our perspective, because we wanted to upskill the PCP, meaning we want to really have them see us, see how we interview, see how we think, and really engage with us. Our model is a bit different, where we decided to do telepsychiatry plus the primary care doctor, plus the patient and the family in the same visit, just for the purpose that the PCP can see how we interview, see how we think, and care for the patient. So that's not typical of the collaborative care model. But again, one of our goals was to train our primary care doctors. So think about what your needs are and be flexible in terms of adapting it. Especially, a lot of people are like, well, how are you paying for this? Two provider in a room with the patient. For the sake of this conversation, I'm not going to go into that. Happy to talk in the discussion about it. But if money is not an issue, funding is not an issue, then you just want to do what is best for what your needs are. You also want to think of how you're going to do it. Is it going to be synchronous? Is it going to be asynchronous? And which part of the synchronicity is going to be with the PCP or with the psychiatry? For us, it was synchronous with the PCP and with the psychiatrist. And there are asynchronous asynchronous e-consult with the PCP and the psychiatrist. So PCP would message me a case that they want to refer. Sometimes I say, actually, just do this. They don't need to see us in the collaborative care model. So there is a lot of e-consult going on as well in the background. We also want to think whether you can do on demand. Is it possible for someone to pop into a primary care visit with the pediatrician and the patient at like their well visit or something, right? Like, can you make that happen where somebody screened for some mental health risks like suicide, and then the PCP could connect immediately to an on-demand service to see a behavioral health specialist? Versus schedule is when it's scheduled on the behavioral health expert calendar at a later time. And I'll talk about on-demand in a little bit in the next case example. But the short is build a model that works for you. So, after you kind of think about what model worked for you, then you want to really design the clinical workflow. Think about how the consult will get in, like how can things be referred, right? And for us, it's referral through the PCP. It's a requirement. Sometimes other our therapists working in those sites also refer, but they have to talk to the PCP first, because the goal is that the PCP is the prescriber. Psychiatrists don't prescribe. In the collaborative care model, psychiatrists don't prescribe. It's really the PCP that do that. And then, so who reviews this referral information? Ideally, it's someone in management but in our program, it's me and the fellows that I work with. because we didn't have anyone to really refer the referral queue, But ideally, it's someone who's not a physician if you're looking at that information from the cost perspective. And then you assign a telebehavioral health person to consult with the PCP. If needed, the PCP either talks to the psychiatrist and just kind of do it basically without seeing the patient. But if needed, the psychiatrist can also do the interview with the patient. And then, and then you document as usual. If you don't talk to the PCP, which oftentimes we can't find the PCP to talk to them, and we just document it, and then and we send them a message through our Epic, and the information gets relayed to them somehow. So that's kind of like a general clinical workflow and the gist of it. But you want to design a clinical workflow that works for you. So some other things to think about is, are you going to do all in person, or are you going to do all video visits, or a mix of both? For us, during the pandemic, we switched to all video visit only. For a year, my fellows didn't go into the primary care clinic. We did everything through tele. But then once it was safe to go back, we did a mix of in-person and video. For some patients who couldn't make it in, we did video visit with them. So you want to think about that, how flexible you are. And then when it comes to kind of a care model, when we're not on the site with the patient, you want to really communicate with the on-site pediatrician office who's going to be in the visit with the child. And for us, we really require that the child has a guardian present at all time. And then there's a thing called a telepresenter. And I'm sure you being in this conference, you probably know already, but who is going to take the vital, set up the room for the patient when the psychiatrist is not there. When it comes to collaborating in the collaborative care model, active partnership is key, good partnership with the sites that you work at. Consenting is also a factor that not a lot of people think about. First, you got to consent for the telehealth service if you don't have a consent for that already. Then you have to have a consent if you are zooming into somewhere in New Jersey, which we do. And I say Zoom, we don't use Zoom. We use another platform. But consenting to a different state, crossing state level, is something to think about too, and you want to talk to your legal about it. And also keep in mind when you're doing primary care into a rural area that there's limited connection sometimes. And so you want to have an alternative connection method. You want to train your staff on what that is so that you connect properly. And also consider emergency management. One thing that people don't understand or don't know is that if someone has a medical emergency or a suicidal emergency in Bucks County, which is a rural area of Pennsylvania, if I call on their behalf, my phone goes to my local downtown Philadelphia police station. So you have to advise whoever on the other side to call so that it goes to their not local emergency service. So those are some things that not a lot of people think about that I want to highlight. You also want to talk about dual scheduling, whether that's something you guys need to do. For example, if I'm seeing a patient with the PCP, well, you need to think about how to schedule that on my schedule and the PCP or community clinic schedule if there's a partnership. So with that being said, I want to talk more about a use case of how you can do on-demand telepsychiatry consultation or telebehavioral health consultation in primary care. So the use case is in adult suicide prevention. And so a little bit about why that is important. So as you guys may know, suicide rates are increasing in the last decade, and particularly even wave surge in the COVID pandemic. And PCP are more widely available than psychiatrists and psychologists and behavioral health specialists. But there's still a low rate of screening due to many reasons, lack of training, those reasons. And it's estimated that PCP only screen for suicide 36% of the time. PCP is also predicted to be effective in suicide screening. I mean, there's many components of that. They already have a rapport with the family, the children, and frankly, 47% of children who seek mental health care is with a PCP. And a lot of behavioral health issues are treated in primary care currently. 70% of antidepressants are written by PCP. And so, if we were to require a PCP to do some sort of suicide risk screening, then it theoretically is minimal financial cost. But that could be debatable once you crunch the numbers. And the screening tool that we were hoping to use was a Columbia Suicide Risk Severity Rating Scale. And that was only 6 short questions. So time-wise, ideally, it doesn't take that much long. So this is going into further detail as to what I just said there, where PCP, definitely more of them. And I'll already have adolescent visit with PCP at least once a year. And that percentage is 54% is CHOP numbers. The other numbers are bunch from different resources. But the idea is that PCP are available, they're there, they don't screen as much, and yet adolescent and primary care treats mental health and psychiatric diseases already. And so we want to make sure if they're treating them already that they're doing suicide screening, right? Because as you know, some antidepressant does increase suicide risk, at least initially. So this is also a graph of the data that hones on to the fact that people are already seeking mental health services in the primary care, and to effectively provide high quality mental health care, collaborating with PCP is ideal, particularly for suicide risk screening. And what we wanted to do is the Columbia, and here's an image of the Columbia. It's really already done. There is already a Columbia suicide severity rating scale that is made for primary care. It has 6 questions. It triages to the patient to low, moderate, high severity already, and it's been validated through multiple research studies. So we thought it was a great tool. So now that you understand why suicide screening is important and why we decided to go in primary care, what's going on at CHOP, or what is going on in usual primary care that we would need to try to fill in the gap? Well, as some of there is lack of screening, right? Lack of screener. And some people, when they do screen, it's based on the pediatrician's own way of asking the question. They just ask one question, or they ask it in different ways. It's not standardized. And there's lack of, even if they do ask, oh, have you had thoughts of hurting yourself recently? There's no triaging way, right? Most PCP are not triaging kids in their head, low, moderate, high. They do it, but it's not standardized. And it's hard for them to gauge as a PCP to understand what level of risk this patient is at. So currently, I'm sure a lot of primary care clinics, everything is a manual process of scheduling, right? Everyone is, you go up to the front desk and then you schedule an appointment with the PCP, and you manually schedule with the psychiatrist, and so a lot of things are manual right now, right? And that is a burden. Not a lot of people think that can be changed, but it could. Things can be automated. Appointment setting can be made by the patient on an app, and you don't even take out the front desk need per se. And then there's also capacity constraints where a lot of our social worker or therapists are seeing lots of volume, but that's because we're not triaging who is appropriate to go to that therapist, right? Maybe low risk, they could just see the PCP and get the collaborative care model and see, and then only those who really need to see a therapist ongoing would be referred, right? So how to triage and how to refer appropriately for the appropriate care so that we don't burn out our therapists is also something to think about, right? And then the therapist has to do manual follow-up with the patient as well. That's also something you want to think, well, is that the most efficient way for the therapist? And then And because there's no standardized way of tracking the patient from screening in primary care to when they actually see a mental health expert outpatient schedule, follow-up, there's a lot of drop-off, and most 60% of patients don't complete treatment. And these numbers are actually CHOP numbers that we crunch. Okay. So wait time, right? Part of the reason why the patient don't follow through with our referral to behavioral health is because there's really a long wait time for them, and by the time they get a schedule with that therapist, their crisis is over. I'm sure people who work in primary care can see that. And these are all CHOPS number. We have up to 10 days to see to identify a therapist. Actually, into the community. So instead of when we refer to our own mental health clinic, it's a long wait time, right? So a lot of times the therapists refer outside, but there's the queue to get referrals outside of the community is still long, 10 days to identify a therapist for a patient. And then there's a wait time to schedule that appointment, and then further onward, there's additional time to reschedule or to schedule the follow-up. So I got a grant from Twilio, and I proposed that how can we fill all the needs of all these gaps in the end-to-end user experience for the patient, right? And so I proposed that we make a software product that integrates different various software components. It's not one sole software. It uses multiple software for the end-to-end user experience. And so the aim is that Linked Care will give access to on-demand telebehavioral health consultation, not necessarily psychiatry. It could be a consultation with a social worker, a therapist, et cetera, in primary care. And the goal is to reduce ER visits and inpatient hospitalization. Because as you may know, during the COVID crisis, wow, our ER and inpatient was overburdened. And so how does it do it? Well, it triages suicide risk severity using the Columbia rating scale and connects the patient to the appropriate level of care. So when it's low risk, we just treat them in the primary care clinic. When it's moderate, when it's moderate, they do a kind of a brief telehealth consult with the on-demand telehealth consult with the psychiatrist for less than 15 minutes, just mainly assessing severity and brief consult. And when it's high, we're like, yeah, this person probably needs to go to ER regardless of whether we do a consult or not. Then we send them to the ER. So that way, the resources that we have at our network is utilized effectively because it's appropriate level of care. So as mentioned, we use the Columbia. So how does that workflow work? So basically a patient has a routine appointment with the PCP, not with me, right? It's like a well-child visit, annual visit. And so the PCP logs into Epic, and the Columbia suicide risk screening pops up and is like, oh, hey, this is a well visit, we suggest you do a suicide risk screening. And then the patient, the primary care doctor open it's really a survey. It's really a form that triages it. And it can be launched in an external website. It can be launched within Epic, whatever it is that works for you. And then the form, input when the PCP input the information in by talking to the patient. So the PCP talks to the patient, get the answer to the question, put it back into the form do the algorithm, and then it turns out, oh, hey, this patient is moderate risk of suicide. Let's connect them to a behavioral health specialist. And so the PCP, the PCP is a top bar. The PCP actually continues with the patient, or they go to the next patient. Once the tool connects to the telehealth on-call psychiatrist by the triaging. Then the psychiatrist sees them for 15 minutes. The PCP goes to the next patient. The psychiatrist ping the PCP to come back when they're done. So it's more efficient time for the PCP for both parties. And then the psychiatrist give the recommendations to the PCP. The triaging, as I said, triage is low, moderate, high. For the moderate is when they do the on psychiatry consultation. For low, we give them an automatic list of referral for community psychiatry, because as I mentioned, there's a long wait list for our own mental health clinic, and we want to send them an automatic referral list that is based on their zip code, based on their insurance and availability. And we maintain a database internally by our case manager so that this automatic list can be generated accurately. And then for high risk, we know they're going to go to the ER. They do need inpatient. Then we page the ED team to tell briefly that someone's coming. So that is how you can use creative software technology, very simple software technology that's already in existence. Generating auto referral is already in existence. The on-call psychiatry is already in existence. Having a form that comes out with algorithm of low, moderate, high is also already in existence. Does it always have to be all connected to each other? The software itself can be broken into those various components by itself, standalone. So you can do just the screening if you want. You can do just the on-call telehealth consult alone. You can just do the referral list alone. But the key is that bringing it all together, it makes the experience for the provider more seamless. So with that being said, I have a few more minutes, so I'm going to jump on what another form of integration so as you may know, mental and physical health is never alone. And with Vita, we treat, and as you also know, like depression and anxiety can manifest and affect chronic diseases such as diabetes and hypertension. And to some of those effects is relating to behavior change, right? Having the patient need medication adherence, doing some behavioral change as getting better sleep, exercise, etc. So one other thing that Vita does is we also triage. We triage mental health by subclinical, mild, moderate, severe, and we see where they are on that spectrum of severity, as well as, and how do we do that? Well, we also connect that triaging of mental health and the triaging of physical health. And when it comes to diabetes, we triage it based on multiple ways, and this is an example of how we triage. And the more severe a patient is, better, higher A1C, higher hypertension needs, then we start to include all the services that we have available, such as adding on nutrition therapy, adding on remote monitoring, adding on a dietitian. But if they're mild and they're at risk only, then maybe the propyl color, maybe they may be, or maybe not. They don't need it, right? So when it comes to the healthcare system, there's limited resources. So triaging really helps us understand the need of the patient and who they need, who's a more appropriate care clinician, whether it's nutritionist, health coach, or a medical prescriber. And with the combination of triaging and to appropriate level of care, we see 33 greater A1C improvement when you treat diabetes and mental health together. And some other good outcomes that can be done when you combine physical and mental health and triaging. You get all these great things like improvement. 76% have an improvement in hypertension and decreased hospitalization by 15%. So I think I am out of time, but I think the format is that we can discuss this first and have questions answering for my session first, and then we go on to Dr. Boyston, is that right, Jay?
Yes, that's right.
Right.
So if you want to stop sharing your screen, we'll pass the baton.
Oh, okay. Okay. Well, one thing is you can also find me on, you can take a picture of that and find me on social media. I'm very active. Feel free to see and such. You can also check out my bio on the MARTA website, and then you can connect with me. All right.
Yeah, on the Metric app, there's a profile page where it has all our contact information as well. So thank you, Dr. Vo. We'll come back to you at the end. I'm hoping we have some time for questions. Dr. Boylston, would you like to share your slides?
Thank you so much, Jay, for having me. I'm so pleased to be invited to share some of my experience today. And I'd love for it to be a dynamic discussion. And so you can get a flavor of some of the things that we've done at my practice, and as well as some of the pain points we've experienced. And just really thrilled to be here with Jay and Christy today. And there were also some excellent questions that I noticed in the chat, and so would love to hit those as well right after my brief presentation. So I'm Yun Boylston, and I am a pediatrician at Burlington Pediatrics and Mebane Pediatrics. And we are an independent primary care pediatric practice located in the heart of North Carolina. And we just recently celebrated our 50th anniversary. Here you can see some of my colleagues, and we have 13 total providers. Of those, 8 are MDs, and we also are really fortunate to have some excellent advanced practice providers who've been with us for a while. And our office is quite lean. As you can imagine, in an independent medical practice, pretty much any initiative you implement has to have a direct connection to the bottom line fairly quickly. Otherwise, it's not very sustainable. And we specialize in what I call generational care, in that in the past 50 years, we are now we now care for the infants and children of and we first cared for like their grandparents. And so, we have children whose grandparents bring them into the practice, who they themselves received care, as well as, their parents as well. And so that's like pretty impressive and actually pretty exceptional from what I gather among my colleagues. And we're also the largest pediatric provider within our greater area, defined primarily as suburban and a lot of rural communities in our catchment area as well. And so, all of this discussion, I think, was really accelerated by COVID, and everybody is aware, these really nice, well thought out, methodical 5 and 10 year plans for digital innovation within healthcare really went out the door. And that certainly included folks like me who are on front lines. And so really, something that we had distant visions about, I think, during COVID, during like February to March of 2020, what really for us would have been probably a 2-year timeline was really accelerated to within like 21 days of conceptualizing, hey, we need to do this because the shutdown's coming, to seeing our first patient. And so some of the things that really required, planning and piloting and implementing, that's one of our superpowers, that we tend to have a good idea and we can pilot and run those PDSA cycles fairly quickly. And so I think that really benefited us. And we saw this as really a survival tool for our practice. In early spring of 2020, our well visit volume, and actually in general, our total patient visit volume went down by 40%, which you can imagine that does not sit very well when we still have, payroll to meet and rent to pay. And so this was really a lifeline for our practice, and still be able to deliver care. We knew that children still needed us. And so we wanted to find a safe way to continue to engage. And really, this was a really exciting time, albeit scary, to really get out of our comfort zone and just tap into some of the imaginative powers that I think we all have as healthcare providers. And so this is a nice snapshot of, well, what exactly is the need? There's a lot of data, a lot of studies coming out now, just in terms of how the pandemic really impacted children, continues to impact children. And, a lot of this is very global, but for us, healthcare is always intensely local. And so we actually ran our own survey among our patient population last January. And this was right during, complete remote learning in our community. And we really wanted to take a snapshot on what exactly do your children need from us as their primary care provider. And, these are just two standard questions that we asked. And you can see, I'm concerned that my children show elements or symptoms of behavioral health issues. You could see the majority of parents who responded endorsed at least one of these concerns, including, anxiety was just incredibly common among the concerns that parents had, acting out, socially avoidant behavior, defiance. And so those are all things that we were keenly interested in. And also the question, I'm concerned that that COVID-19 will have long-term effects, on my children's, physical health ranked up there, but, mental health scored incredibly high at over 40%, as well as social skills. And so this is the tremendously long shadow that COVID has cast for our generation of children, and that we'll continue to address for quite some time. And so how does that mash up between, this innovation that we really, hit the ground running with quickly and serving this need? And so I'd love to share just a snapshot of how our behavioral health model works. And so for us, I would define our behavioral model. So we have our core, we have a behavioral health team comprised of a management level, clinically trained nurse, and she is our lead care coordinator. And you'll get to see a photo of her in a minute. Her name is Miranda. And up until very recently, the other dyad on that team was actually a PhD level clinical psychologist, Dr. Capito. And she joined us right before the pandemic, and just what a godsend she was in terms of implementing our behavioral health program. And so those are our two primary leads. Psychologist, lead care coordinator, and then really encompassing the entire team is actually our administrative staff, because they're the ones who are utilizing the behavioral health appointment scheduling. They're the ones that patients interact with first when it comes to scheduling these appointments. And our clinical team, benefits from significant training in recognizing signs and symptoms of behavioral health conditions, because they're getting the phone calls about, hey, my kid has chronic headaches all the time, and I'm really concerned that they're anxious, or other elements that may not be quite so obvious and actually can be quite nuanced. I think any primary care person on this call today recognizes that pretty much every visit is a behavioral health visit, or every presentation can potentially be a behavioral health presentation. Because people don't come already self-diagnosed. Oftentimes you'll have a visit for, chronic abdominal pain, and you peel back the layers, and it's actually just, severe presentation of anxiety, and that can take time and skill to be able to dissect that. And then certainly the foundational part of our behavioral health team is our providers. And so among our 13 providers, we all practice we all manage behavioral health conditions. And as you can imagine, diverse experiences, diverse clinical interests. And so really the goal was, we recognize this is a need. Everyone needs to do this, just like you can't say, oh, I don't do 4-year checkups anymore, right? And so it's a need. We recognize it's good care. We want to maintain a consistent and high quality of care among our patients. And so we really need everyone to step up and be able to do this. And so part of this is a use case that I'd love to share with you in terms of how a behavioral health visit or encounter might start. And so this is Jada, and of course Jada is not her real name, but she is a 16-year-old young woman at my practice, and I've known her since she was in grade school, and has always been incredibly bright and accomplished. And her mom came in a while back and with her younger daughter who has special needs and complex medical needs. And she said, I'm just really concerned about Jada. I think she's just really depressed and I don't know how to get through to her. And I said, hey, how about this? Let's talk about, what your concerns are. I would love to connect with Jada. How about how about if I meet her via a telehealth visit? Do you think that would work for her schedule? Do you think that she would be comfortable with that? And so, and her mom is so appreciative. And she says, absolutely. Jada is a senior or is a junior in high school. She's got all this stuff going on, but I think we can schedule some time next Wednesday, when she's free. And so Jada's mom, we go up front and we schedule a telehealth visit for Jada. And at the same time, I send a message to Miranda, who is our lead care coordinator with our behavioral health team. And I say, hey, Miranda, would you please follow up with Jada's mom and Jada? And I'd like to do a couple of things. So one is, would you please share with her the community therapists who are partners with us and that we know can offer a fairly convenient and quality therapy experience? Check. And then I'd also like for her to go and complete the PHQ-9 and GAD-7 screens. And I would like those results back prior to our telehealth visit. And so, so everything's kind of working in the background. And then on the day of Jada's telehealth visit, our front staff contacts Jada's mom in the morning and to confirm the appointment and to collect any copay if that's applicable. And then they get a link to the visit. And then when she signs on, our front office, connects with her and says, hey, Jada, how's your connection? Hey, we need to work on your audio before we can connect you. And so once everything's ready to go, Jada is still in my schedule. And she is just like every other visit, from the 16-year well visit to the 2-month baby checkup, to the runny nose, and then Jada. And it says, the template says, telehealth at 3:40, and then the flag on the schedule says patient waiting. And so when I see that, that means that Jada is in our telehealth waiting room, ready to be picked up and for the visit to be started, just the same way as if a patient has had their vitals checked and they're now and so, I click on, Jada's encounter in our DocCME platform, which is the one that we use. And Jada and I have this discussion. She's very comfortable at home. She shows me some of the succulents that she's had. And she says she's been trying to work on her garden, indoor garden, because it helps with mindfulness. And so I've really enjoyed seeing these little snapshots of people in their natural element. And we talk about what's going on. And Jada can open up to me because we know each other really well. And she knows that I've been part of her healthcare support team for many years. And we talk about how medication might be a good option for Jada, some of the things that she would want to look out for, including side effects. And then we say, let's try this. And you contact me in the meantime if anything comes up via portal message or call me. But otherwise, I'll see you back in a couple of weeks to see how you're doing. Some of the context of telehealth, and as I mentioned, it's got to work within our current workflows, and it's really got to work within the context of all the other primary care, because this is, it's primary care telehealth. So it's the integration part that's got to be integrated into all the other work that you do, right? And so I think this is a really good snapshot to show that overall, telehealth has to work for your practice, not just for behavioral health support, but what else has it allowed us to do, or what were some of the pleasant surprises that I've had? And so I'd love to share those with you. One, I found that it really is a great way to expedite care and also to increase revenue. And so you have improved same-day urgent care access, and a lot of the phone calls that we used to get that we would say, hey, where the nurse would be on the phone talking about a call baby for, for 15 minutes and not really, it's a good encounter, but one, you're not billing for it. And the parent isn't thoroughly satisfied because, Dr. Minter is the one that she really wants to talk to. And so this was a great way to say, hey, you know what? Are you available now? Because I can get you into a telehealth spot, in 2 hours. Would that work for you? Right. And so that's been received really well. Warm handoffs are something that we use really effectively within our practice and certainly within our behavioral health team. During COVID, our behavioral health team and Dr. Caputo were completely remote for safety concerns. And so even though we were in the office, if we actually had a patient in the building, we would say, hey, let's log on and let's meet her together. And I'm going to introduce you. And then you can take it from there. And then I would move on to the next patient. And then Dr. Caputo would wrap up or make plans for subsequent encounters with the patient. The other parts of telehealth that I found incredibly useful is actually to really improve the care coordination process. And so during COVID, especially for our complex medical needs children or our medically fragile individuals, this was a way to help connect with them, see how they were doing, see if they had any therapy or medication or referral specialist needs, all the things that really go to support care. And I was able to still document, hey, I had face-to-face encounter times, and this order needs to go through without having to call and say, hey, I know you really need this durable medical equipment, but can you come in? And I felt like that this was a really good use of providing care, but not putting patients at risk. During COVID, it also helped create a leaner team dynamic in which we were really able to deploy staff to do other things like just really aggressive drive-through testing and phone calls. Because with our telehealth model, really the clinical nurse dyad is not functionally an important element within the telehealth encounter. And so that really freed up my nurse to be able to do other tasks for my other patients. And speaking of, staffing, staff optimization was really key because, in spite of best efforts, we had a lot of staff. It was very volatile in terms of who was going to be able to come in, who was exposed to COVID, who has COVID, and who needs to work from home right now. And so this really opened up a broad range of options. I think the particular surprise to me in terms of how telehealth was applied for behavioral health needs was actually just really expanding our footprint. Meaning, so I'm licensed to practice medicine in North Carolina, and I realized in retrospect that, or in hindsight, that for a lot of my patients who really needed me most was when they went off to college or went off and moved away, and they were unable to see me. And so one of the bridges that I have is, as long as you're in the state of North Carolina and you're at Appalachian State or you're at Eastern Carolina, we continue our behavioral health work together through telehealth. And so they will find a quiet corner in the student union and have anxiety follow-ups with me and tell me how things are going. And I think that's so incredibly important because the feedback by all accounts is, in terms of higher education and colleges, they were just absolutely inundated and drowning with demand for behavioral health care, and they were unable to meet that need. And so I feel like that is one way the primary care providers can really bring value to these individuals who are in transition as young adults. And one of my favorite stories to tell in terms of how I feel telehealth has revolutionized this process is I had a 12-year-old patient whose dad was critically ill during the COVID pandemic. And he was actually in the ICU in Raleigh. And his mom called, so this child's mom called and said, I really need, Jack to be seen for anxiety. We need to talk about this, but I cannot get him into your office. I'm here with my husband in Raleigh. And I said, let's do this. Well, let's do a 3-way call because Doxy and me can do that. So you log in at the same time. And then Jack, who's with his grandmother, at home, an hour away from Raleigh. Let's convene a 3:30 call, and then you can drop off, and then I can talk to Jack, and then we can really group together and come up with a plan. And I just, that was such a light bulb moment for me, because I really felt like this is what medicine can be. Please don't take it from me. This is, I really wanted to bring some of the voices from our team in terms of how they feel about behavioral health, or how they feel about telehealth as it applies to behavioral health. And I snicker a little bit because it's always funny when you see like the provider side of it and our staff side. And so Trevor is a very experienced PA at our practice. And he says, when it all works well, I get the feeling that the patients and their families like it a lot. This saves time. And I think this is really funny because for all telehealth providers, you know that the big asterisk is when it all works well. And I know what he's talking about. So because we have a lot of rural communities that we serve, the broadband and connectivity issues are major. I would say probably about 1 in 4 calls are still really low or poor quality. And often we'll have to divert to, hey, what's your cell? I have to call you on that, or we have to do this in a different way because we're unable to complete the visit. Dr. Minter, one of my great colleagues. She says mental health services are perhaps the most frequently used. And so I would absolutely agree with that. My patients with ADHD, depression, and or anxiety use these appointments for follow-up. Miranda, our lead care coordinator, says telehealth is not only the new norm, but a new way for medical professionals to interact with patients without barriers. And Amber Davis, who is a longtime receptionist, and I think hers is absolutely just divine. I feel this is one of the best things we've done to promote immaculate patient care at our practice. And so I love that everyone at our practice has been so supportive of this initiative. But, you know, it's definitely still got challenges. And so kind of the focus and the potential for how we view our behavioral health program in terms of telehealth. Sustainability is a really big issue, and that's probably 1, 2, and 3 in terms of the context for how independent practices or smaller practices can implement, and maintaining a high standard of care. We're always striving for that, and then continuing to innovate. For us, a really big foundational initiative in order to do this correctly has been professional development. And we're so blessed in North Carolina. So we actually have the North Carolina Psychiatry Access Line. We call it NCPAL. And NCPAL means I have a direct number that I can contact a Duke child or adolescent psychiatrist. And they do not bill and they do not interact with the patient. This is different from a collaborative care model, which is much more formal. I would consider this a psychiatric phone a friend. And so this might be everything from, hey, this kid can't get in with their regular psychiatrist, or their psychiatrist is no longer there and the wait time is like 4 months. And he's on this dose of risperidone with risperidone with, and he's got anxiety. How would I manage this, as a bridge? What can I offer? And so those are the kind of questions you might ask. Or, this kid's on 100 milligrams of sertraline, and by all, accounts, including GAD, it looks like we're not at therapeutic level. But what are my options, right? And so that's been incredibly helpful and really helps decrease anxiety in terms of, hey, I think I can do this, right? So, it allows primary care providers to take that deep breath and say, I think I can do this, and move beyond my comfort zone. The other really critical element for us has been what's called the REACH training for primary care. And I believe this has actually been expanded across the country to other locations. But REACH training is basically behavioral health training for primary care providers. So it's like an intensive 3-day module, and then you meet weekly over a defined number of months for everyone to present a case and to learn from each other. And this has been a really invaluable experience for us, enabling us to deliver our, behavioral health, visits and free. So that's like a big buzzword for us, very compatible with our current schedules. And so we currently have, I think, 2 providers about to enter the next training opportunity. And we have, I think, 4 or 5 who've done this. And so I would say at this point, it's kind of the majority, very close to the majority of our providers have done this. And we've also implemented in-service learning, particularly when it comes to suicidal screening. And this is the safe tree. And so I will readily admit, it wasn't that long ago when, a parent would call and say, hey, my kid says he wants to kill himself. And we are just screaming, go to the emergency room, right? And it just makes me kind of ashamed and really sad that that's the way that we used to handle situations like that, because we all know that, hey, a lot of times we just need to take a deep breath first and then try to be there for the patient. And now that we're more experienced and seasoned, we know that the ER, especially during a pandemic, was not the place for a kid to wait, probably up to 12 plus hours. And then to basically say, hey, if you say you don't want to kill yourself anymore, you can go home, right? How is that good care, right? And so we really are, I feel like that's the one thing that we've really improved on, that we feel comfortable seeing them and at least screening to the level that we're comfortable with, and also understanding our lane and understanding when and how to really escalate care for individuals who do have active suicidal ideation. And as part of that, that's, with our behavioral health protocols, a lot of this work is very much in working through clinical workflows, because, well-intended things can certainly be good ideas, but it's not until it translates into workflow that you really see if it cuts the mustard. The other components of kind of the essential parts of sustaining behavioral telehealth is telehealth payment parity. And so, during the public health emergency, a lot of insurers paid for telehealth visits. And so they're starting to cut back on that. And that's a big issue. One is, it really prevents us from getting paid to do this good work that improves access to care. And 2, we never take on initiatives that we know will result in fractured care, because we have a commitment not to treat our panels separately. So a Medicaid child should not be treated any differently, better or worse than a Blue Cross Blue Shield or our United. And so, that's an uneasy space for us, when payment issues become a problem. The other gold nugget that we found in our work to be successful is really embracing our community partners. And because, when you start doing these visits, you realize really quickly, hey, we've had to do a lot more CPS referrals as a result of some of these visits, that it's been so critical to talk to schools and to school nurses, school administrators. And so some of the stuff that we've done actually is, like, for CPS, our local CPS, we said, hey, you do incredible work, but I bet nobody buys you lunch. And so we, and during the pandemic, we said, well, we'll do a virtual lunch. And so we're just going to send $20 Chick-fil-A gift cards for everybody there. And so please use this on your own time, but we would love to have a lunch and learn and just to see your face and your name, and hopefully get a, bat phone line. What we really wanted was like a secret access number. We got something kind of close, but, it was really to be able to meet these individuals who were doing like just champion work, and to be able to connect. And so the next time I got on a phone for what is almost always an urgent, high pressure situation, because this involves child neglect or abuse, say, hey, hey, Elena, I'm so glad I got you on the phone. Can I talk to you about this kid? And so that's actually been incredibly beneficial. And the same goes for our behavioral health network. We did the same thing, a little lunch for our local adolescent psychiatrist and his team at his clinic, to be able to say, hey, we really value our partnership. What are some ways that we can do things even more closely? And what can we do for you? How can we make your jobs easier when we send these referrals to you? And so I think that's all work that actually is done behind the scenes and outside of the examining room, that continues to bear fruit. And lastly, advancing care delivery. And so I think this is kind of the next phase, a collaborative care model, which, is really, that's kind of I think the aspirational goal for anybody in primary care, just because there's a lot of data to show how successful it can be. But really for us, it's, hey, are there, billing codes that are reimbursed, right? And so it's really getting down to the granular level of, can this work for our practice financially? Because the idea is really good, but the devil's always in the details, right? And so we've actually worked really closely in partnership with the North Carolina Pediatric Society to really advocate for some of these things, so that it can be in place for us and for other clinics that desire to do this work. And then really expanding, what can this also include, we'd love to be able to do more like early childhood mental health as well as assessments. I think this is all, there are going to be so many nuanced things that come out of COVID and really just impacting people in different ways. And so we want to be prepared for that. So I just want to thank you for your time. Please feel free to contact me. I would love to be a connector. And so if you would like to learn more about NC PALS or the REACH program, I can definitely put you in touch with folks who can make that happen. And certainly anything that I can impart or share with you, that would be great too. So let me stop sharing.
Thank you so much for your presentation, both of you. This is really great. I want to ask any questions from the audience. I have a few of my own, but you guys have questions you want to ask them about their care models or how they've rolled this out or challenges they've had along the way. See, Dr. Vo's been already at it, answering questions. Thank you, Dr. Vo, for that.
Jay, I'd love to answer or to address the two questions from Gwendolyn and Deborah, who've been very patient, but they also added some things into the chat box, if that's okay.
Yeah, go ahead.
Okay, great. So the first question is from Gwendolyn. Say, for instance, you have a child in foster care or being seen with someone other than their legal guardian. How do you handle that? And do you have the parent sign consents prior? For us in the routine care ambulatory setting, this would all be baked into the consent to care, which is updated anytime there is a change. It's updated minimum annually or anytime there's a change. And so certainly if a child is entered foster care, we would update that with their legal guardian. And so the routine care would be encompassed in that, developmental screens, like depression screens. In North Carolina, we also really rely on the minor's right to consent. So 13 and up, that would include contraceptive, STI screening, and mental health care. And so, and that allows, individuals 13 and up to receive care for those specific conditions with some restrictions. Without consent from a legal guardian. And then also in North Carolina, specific to foster children, if there's an emergent situation involving mental health, then the county DSS director has the authority to grant consent in those situations. And so really understanding how the medical legal aspects or the state statutes apply to you are pretty important when it comes to behavioral health care. And then Deborah's question, how has the upskilling been received by PCPs? Do they feel overwhelmed with more responsibilities added to their workload? This is such a great question and really hits the tip of the iceberg, I think, because, everyone's burned out, right? And so for a lot of providers, it's like, you want me to do more, right? And but I think that when we approach this as, hey, this is really good care, and this is going to really address all the pain points and the unnecessary cognitive burden that you experience and actually make you want to take care of these patients, right? And so, prior to really becoming more seasoned in behavioral health management, I realized I didn't really like these visits, and the reason is I understood that it was really about me. I didn't like the fact that I wasn't experienced or felt inexperienced. It had nothing to do with the patients. I really wanted to provide care, but really just, looking inwardly, it's so, okay, well, the need is there. You're going to have to do this. So, and I kind of had to have a pep talk with myself. Either you learn to do this right, or this is going to be a really painful career. Right. And I think that once I kind of got over that, that mental barrier. But I think having run through a couple of scenarios, the first time you see a patient who endorses suicide, I mean, that is monstrous. It will absolutely kill your day, and forget about like the 5 other patients waiting, right? But, once you've done this, the right questions to ask, and your blood pressure doesn't go up quite as much. And I know, Dr. Vo, you know what this means, because you probably get a lot of these frantic phone calls from primary care doctors. And so really learning how to really check your own pulse and then say what needs to be done. And I think that, and having those people, those support people, because you're not going to save the day, right? But you can connect them to the people where you can connect your patients to where they need to go. And I really see that as my role. Dr. Vo, do you have anything to add to that?
Yes, thank you so much for that firsthand experience as a primary care provider. And you're right on the spot, where it really was about comfort level, right? Being comfortable with what they know, and being comfortable with having that support to go to. And at CHOP, that's what we hope to provide, as in the second example I gave of how we do suicide risk screening, how it use Columbia, the Columbia Suicide Risk Severity Scale. And I put in the chat some more information about that for those in the audience. You can just Google Columbia Suicide and Lighthouse, and the website will pop up. Kelly Posner is one of the founder of the Columbia scale. She's lovely. She was happy to be a consultant on my project. So I just want to give you guys those resources. And when it comes to like upskilling and PCP and like working with them, I think that's my aim of the goal, is to really just help them simplify things for them, right? As a psychiatrist, I really break it down. These are the most important things you need to look into, and this is the next steps. Because when it comes to suicide and like really working with behavioral health, what PCP really want to do, in my opinion, is that what is the next step, right? And when the PCP screen for suicide and they don't know what to do next, why would you want to screen if you don't know what to do next? As well, it's uncomfortable for you, and it's largely, some would say that that's poor quality care. If you screen and then you don't have anything for them to refer to, you don't have any resources for them. So the aim of the project that I was working on in my second example that I talked about was really to provide the support and resources for the PCP. And keep in mind, though, while I brought it up as a series of software tools, it's really not hard to replicate in other places. So I'm happy to talk more on one-on-one about how you can do that for your entity. And so you're happy to talk more offline.
So thank you for that, both of you. There's another question that came in from Khalil Hassam. If you guys, one of you want to take that question about support for rolling this out? And I guess the question also is, how much funding, does it take funding to roll this out? Or is it more just managerial agreement covering to kind of give that space to do that manual work?
Yeah, I can touch that if Dr. Boyston wants to as well. In short, when it comes to, well, you have to break into category, right? If you're talking about telehealth reimbursement, it depends on the payer, right? You want to check your payer contract with that payer, whether they will reimburse or not. A lot of private payer, Aetna, et cetera, are paying for it. And Medicare, Medicaid is also, it's in the newest coding document that they have. In terms of collaborative care model, that's harder to get paid for. But in the new fee schedule, there are some codes in there that you can use for a collaborative care model. There's also a way around it, not around it, but there are ways that you can bill using your time spent. If you use the code that is time spent instead of element-based, but time-based, that is a good way to bill for the pediatrician time, that the extra time they spent talking to a provider, a specialty provider, or the time they spent care coordinating, counted in that time spent code, like the 99204, et cetera. But in short, there are ways to get billing support for this. You have to dig deeper to find out what those codes are. And in terms of support, matron here, this conference, I'm sure a lot of people here can be a resource. And that's how I kind of started, just by talking to people that I find has the expertise that I'm looking for. And so, as mentioned, I'm happy to talk more about how I can help you guys build a telehealth, behavioral health, primary care model.
Thank you. So,
and Jay, if it's okay, I'd love to chime in. I think
Sure.
I love Dr. Vo's suggestions. I think being a primary care provider, I would recommend that Khalil do a couple of things. One would be really focus on the practice management piece, or approaching practice managers, because they're the ones who are going to deliver this to the providers. And the things that I would go to them would be like a cheat sheet on all the codes to use in terms of, hey, these are the CPT codes for a PHQ-9 or for a Vanderbilt. And then like the Medicare reimbursement rate, if that's available. And then also to be able to offer kind of bite-sized bits, especially for providers, because, I know, and this is just a guilty admission, typically when you hear like integrated behavioral health or collaborative care, your eyes just glaze over, because everyone knows it's a great idea, but no one really understands what it is. And so being able to have a peer walk through that journey, or, hey, how does your day look different because you've done this, right? Or probably the questions that really most providers want to know, does documentation increase your day, your work day, right? Like what are the pain points that you have now, or what's actually been solved for you? I think those are probably like the pinnacle questions that most providers going to ask, because the spirit is willing, but the body is weak. And so the last thing they want to do is take on something that's going to make just getting through the day harder.
Yes. We also have another question on the chat. Joshua Bradley asks, how have you been successful at getting PCP comfortable with prescribing in the collaborative care model? We have a lot of resistance to this, so the psychiatrists and NPs prescribe. So yes, there is there is some resistance in all entities, in all groups. One way that I like to, when I built the telepsychiatry collaborative care model to these distant sites, I was working with PCP that were an hour away, 20 minutes away. And one of the way I convinced that they should be prescribing is the fact that I told them the aim is to train these NPs and these PCP on how to feel comfortable prescribing, so that in the long run, they don't need my service anymore. They can just do it and bill, like Dr. Yun was saying, utilize those codes and provide efficient care, quality care for their clinic, but also, it is a way to increase revenue. So I use that, and I was like, well, if you don't prescribe yourself, you don't do the act of prescribing yourself, you really won't feel comfortable, right? Just as like all of us go through residency training, we do the prescribing, we do the ordering, we do most of the work. So that was how I kind of framed it as, like, you have to do prescribing, you have to be doing the patient education to really understand it, to really get comfortable with it. Is that how I approach that persuasion?
Just to add to that, Joshua, I'll tell you a couple of things. I think for our providers, the biggest hurdle was the black box warning, and nobody wanted to get sued. Like when it really comes down to it, I think conventional training has kind of hardwired some of that into primary care providers, like mental psyche. And so I think there are some good ways to kind of help kind of toe the water and really become more comfortable. One would be maybe coming up with just a looser informal agreement that, hey, if this person has been on a standard SSRI monotherapy, for 3 months, has been on a stable dose and is doing well, would you be comfortable taking over that care or management? And I think that a lot of providers might be willing to do that, even if they're not quite up to speed on initiating medication. And so that would be a great entry point for a lot of providers. And I think that the other argument, similar to Dr. Bo's point, is, as a PCP, you have to do a lot of things that you're not super comfortable with, right? So including managing birth control, managing blood pressure medicines, managing diabetes medications. And so, all of our skill sets are quite different, but I would say to compartmentalize behavioral health care within the primary care setting is frankly unfortunate, and just kind of saying, hey, this is what we do, right? The need is there. And so we'd love to give you the support to be able to do this for your patients.
So I had a couple of questions. Would you recommend layering some of your model, like a piece at a time, to kind of slowly acclimate your staff? And then another part, two of the question is, how do you go about onboarding your staff to these changes? Because we don't like change. It's funny, we're mental health providers and we always like the change. So how would you go about, would you layer these services over time to kind of get them used to it? And how do you onboard your staff?
Sure, I can answer first. When it comes to, in terms of layering, I present it in such a way that it just came about as is the full model, but it definitely didn't come about that way. First, we started out with just me working with NPs in the rural area, in the further away primary care sites, and that was me in the visit with the PCP and the patient. Then the PCP started doing the patient alone. And then I start adding, and that was scheduled services. Then I started adding, well, you know what? Sometimes sometimes in the day that I'm not on schedule with you guys, there are people who have questions about behavioral health and psychiatric needs. So let's do this on-demand thing. And so I had added on demand. So in terms of tiering the services you can provide, you can break it up into those type of services, right? By tiering it. And you can also tier it up by the type of primary care worker that you work with. I started working with NPs. And somehow our NPs are more enthusiastic. and then I started, and then a more pediatrician got involved. So I think whoever bites first is my recommendation. Pitch it to many different services or many different programs, and whichever seemed like the lowest hanging fruit and the less resistant, then you work with that and you build the model that fits their need. Again, it's all about fitting their need. What is their need and how can you fulfill it? And then once you fulfill that need, you can layer on other things.
You don't have to start with the grand, perfect plan. You just have to start with something small that you think is low-hanging fruit, experiment with that, and then layer it as you learn lessons as you go.
Yes.
Great. Dr. Boylston, did you want to address that?
Yeah, I would absolutely agree to you. I love the, one, it's got to be customized to you and fit your needs. So I love that point, Dr. Bo. And then the digestible bites, for us, the journey, the arc is actually quite long. We initially started this work years ago, and it was just to improve screen. How do you improve the screening process? And if you start there, you can actually get fairly far ahead, right? Because you got to know what to look for if you're going to treat it. And so, are you implementing the PHQ-9 at every well visit? Does everyone have one over the age of 12 in your practice, that's active? And then the other parts are having champions in the practice. To Dr. Vo's point, work groups are really essential, but only if they have all stakeholders represented. And so you can't have a work group that's going to implement all these workflows and all these ideas if the nurses aren't involved, if the schedulers aren't involved, and it's just a bunch of providers creating policies that don't have the 360 lens on it. And then I think, toolkits, everybody uses a toolkit, but create a toolkit for your practice. So, we have bins essentially of, hey, this is where you go. This is the ASQ suicide screen. This is where you get it. This is the list of all the referrals, or community partners who provide therapy in our area. You can just pass that to a patient. And so you'd be surprised how just being able to grab something out of a designated space and being able to hand offer that to a patient really helps expedite care and breaks down barriers in terms of being able to do this work.
That's great. Any final thoughts, Dr. Vo and Dr. Boylston, as we close up here?
Jay, I just want to thank you and Dr. Vo for this really engaging discussion. I love our attendees. Your questions were spot on, and it looks like everyone's quite motivated to do this great work. So thank you for this opportunity.
Yes, and thank you so much. I want to second that. It's been great working with you, Jay and Dr. Boyston, and thank you for everybody for attending. I also want to recognize that, I put my email in the chat, christyvo@apa@gmail. So feel free to contact me. Happy to talk more. I love collaborating with different entities.
Great. Thank you all for attending and for your great presentations. We'll hope to see you again soon. Thanks.
Thank you.